So up next in our platform for the morning, we have Dr. Anupama Kali, and she's going to speak this morning on non-motor symptoms. Dr. Kali.
Okay. Hey, everybody. So I am Dr. Kale, not Dr. Kelly. I know that sometimes we get a little confused. But I'm going to be covering a pretty broad topic today. My talk today is by no means exhaustive. It's just basically going to touch on some of the more common non-motor symptoms. There are going to be some that are missing, but hopefully there will be some take-home points at the end of the talk. So just to start off with, before we go into non-motor symptoms, why are we even talking about it? So as we know, Parkinson's disease is classified by its motor symptoms. And in fact, much of its recognition and clinical diagnosis is based on these, what we call cardinal motor features. And so when you come to your neurologist or your general practitioner or even your movement disorder neurologist, you're going to be coming and presenting with motor features. So a lot of you will have slowness of movement, some stiffness of movement. A lot of you will have a tremor, but about 30% of you may not. And you'll also have balance problems. So postural instability comes into play a little bit later in the disease course. And so when we even look at motor symptoms, when PD was first described back in 1817 by James Parkinson, he actually focused a lot on the motor symptoms, including tremor, but he was able to recognize that there are some non-motor features that are involved, and he even touched upon sleep and some of the other non-motor features. And so, again, why are we talking about non-motor symptoms? So we've now recognized that non-motor symptoms are integral to Parkinson's disease. They can, in fact, be a presenting complaint in greater than 20% of patients, and actually has a greater impact on the quality of life compared to motor symptoms. And they can, at the end of the day, be often the predominant source of disability in advanced Parkinson's disease. The problem is that non-motor symptoms often go under-recognized, especially earlier in the process. There's a lot of reasons for that. But particularly, some of these symptoms, like Dr. Cloud talked about, constipation, they can be very common in the general population, and they're not necessarily specific to Parkinson's disease. The other issue is that it can be difficult to differentiate between what is actually a non-motor symptom that's due to the disease, or is it a side effect of one of your Parkinson's medications. So this is kind of a schematic as far as what non-motor symptoms are involved in Parkinson's disease. And it can be pretty overwhelming, you see all these things branching out. It's easy to remember if you can kind of put them into 4 categories, okay? So non-motor symptoms often involve the sensory systems. They can involve autonomic dysfunction. Sleep disorders are a huge part of them, and then neuropsychiatric problems. And in here, they've kind of forgotten to mention cognitive impairment and dementia, so I've kind of highlighted that there. And so as far as non-motor symptoms are concerned, they can occur at the onset of the disease. They can occur during the disease course. And many of them, or at least 4 of them that we've been able to recognize, can occur as preclinical or premotor or prodromal stage. Those are mainly a lack of sense of smell, REM behavior disorder, depression, and constipation. Some of the other non-motor symptoms that we learn about or hear about, they occur more often in later stages of the disease, namely dementia and cognitive dysfunction, hallucinations, orthostatic hypotension. So this is just a general idea of how often these symptoms occur in patients with Parkinson's, and you can see that they're very common across the board. Olfactory dysfunction, a lack of sense of smell, is very common. It occurs in upwards of 90% of patients. But you can see that autonomic dysfunction is very common as well, as are sleep disorders, as is depression. So just to kind of touch upon some of the sensory symptoms that some people may experience, olfaction or olfactory dysfunction is one of the most common, as I mentioned before. It can occur in greater than 90% of patients with Parkinson's disease. The problem is it's not often reported by patients. That's because changes can often occur gradually, and up to 70% of people can be unaware of the loss. The only reason I mention it is that, as I mentioned in the previous slide, it can be a potential preclinical marker of disease, and so it's being looked at a lot in research. Unfortunately, no current treatments are necessarily available at this time. Moving on to autonomic dysfunction. When people display autonomic dysfunction, it'll often manifest as 4 different types of symptoms: orthostatic hypotension, constipation, urinary dysfunction, and sexual dysfunction. One thing it's important to remember is that if you have any of these features a little earlier in the disease, you may want to consider an atypical Parkinson's process or a Parkinson's plus syndrome. So, orthostatic hypotension. A lot of you will come to your neurologist and talk about drop in blood pressure, and they'll say, oh, well, you're orthostatic. So what does that actually mean? So when we actually go change from a sitting or a supine position to standing, our blood vessels actually contract to maintain our blood pressure to our brain or our blood perfusion, as gravity is kind of pulling it downwards. But in many of you, this will at one point be impaired. So what is orthostatic hypotension? That's when you have either a drop in systolic, or the higher number, by about 20 points. It can be a drop in diastolic blood pressure by about 10 points, and that's always within 3 minutes of standing. So a lot of times when you change position, so if you go to stand or occasionally after large meals, the common symptoms that people usually experience are lightheadedness. They may have a sense of fatigue. Oftentimes people describe what we call kind of a coat hanger headache, pain in the back of their neck, kind of their shoulders, almost like a coat hanger is placed on their shoulders. And they can sometimes even have cognitive slowing. It's important to remember that dehydration can make this worse or trigger this. And dehydration, as we know, is very common as we get older, or basically in the general population. Another thing to be aware of is that it can be caused by some of your Parkinson's disease medications. Main offenders are those dopamine agonists. So Mirapex or Weekrip can often drop blood pressure. Sometimes Sinemet can, so it's important to discuss maybe adjusting these medications with your doctor. But at the end of the day, it's going to be important that this be optimized, because it can contribute to an increased risk of falls. Now, I've intentionally left off, before I go on to this slide, just so you know, I've intentionally left off constipation because I knew Dr. Cloud was going to be speaking about it today. But other management techniques, basically we really focus on non-pharmacological measures if we can. That's going to be making sure that when you go to change positions, say you're getting up even after lunch today, you want to make sure you do so slowly. You want to make sure you adequately hydrate yourself, especially in the morning. This is one of the times, or one of the only times, that a doctor is going to say make sure you get a little more salt in your diet. Go ahead and eat those potato chips. Avoid big meals, maybe smaller meals. You can elevate the head of your bed at night, and you can also use compression stockings. Now, they can be a little cumbersome, but they can be helpful. Again, when we want to address them pharmacologically, we forget that a lot of patients are actually hypertensive, and have been on antihypertensive medications for a lot of their lives. So it's going to be important to make sure that you reassess the need for that. So it may have been that 10 years ago your blood pressure was high, you were placed on all these medications, and now you don't necessarily need them. You can also adjust your Parkinson's disease medications. As we mentioned, there are some medications in particular that can drop your blood pressure. And then only then do we start to think about how to treat that drop in blood pressure. And these are some of the common medications that are used. So Florinef, Midodrine, Mestinon, and the newer medication, Droxidopa or Northera. So moving on to urinary dysfunction. So this, as you can see, is also very common in patients. It affects upwards of greater than 50% of patients. This is usually due to a hyperactivity of one of the bladder muscles called the detrusor muscle, and it can lead to a range of symptoms. Urgency. People have urinary frequency, can have some urge incontinence. Nocturia, or going to the bathroom frequently at nighttime, is very common in patients. And of course, as you can imagine, if you have to get up at night multiple times, and then you're not so fast at night, then you're at an increased risk of potential falls. So again, some non-pharmacological measures to take care of urinary dysfunction. You want to make sure you reduce fluid intake in the evening, avoid diuretics, try not to have that nightcap or don't have a cup of coffee towards the evening hours. You can practice time voiding. pelvic floor exercises. Medications, sometimes those that are prescribed maybe by your primary care physician or even a urologist, some of them can cause side effects, including confusion. So one of the main offenders is oxybutynin, for example. If it gets to a point where that's become very bothersome, that's when you can start to consider a little more maybe aggressive treatment measures like botulinum toxin injections, which are going to be performed by a urologist. And then it's also going to be very important to go see a urologist because, as you know, you can have some of the same symptoms or similar symptoms due to other conditions that can be, common in aging. So, for example, for the men in the room, benign prostatic hypertrophy can cause urinary frequency. So moving on to sexual dysfunction, this is just a short slide. Sometimes it's not mentioned very often, but it does also affect a lot of patients. You can have erectile dysfunction. You may have decreased libido. The erectile dysfunction itself usually occurs as part of autonomic degeneration. Sexual dysfunction can also be due to a number of other issues. You may have motor dysfunction. It may be a side effect of medications. You may also have a comorbid mood disorder that's causing problems. It's for some reason sexual dysfunction is reported more commonly in men. It's probably because that's more easily identified. You can also have the other side of the coin, hypersexuality. These are usually due to side effects of medications. Again, dopamine agonists are known to can potentially cause impulse control disorders, so increased hypersexuality, increased gambling, other compulsive behaviors. So sleep. So as I mentioned before, sleep is a very common complaint for people. There's a range of sleep disorders that can affect patients with Parkinson's disease. And a lot of times we kind of just throw these terms out, but whenever I do talks for patients, I always like to include definitions because sometimes we get so used to talking about them, we may not explain exactly what they are. So REM sleep behavior disorder, that's one of the prodromal markers that we talked about. It can occur potentially 10 to 15 years prior to development of motor symptoms, and that's when someone acts out their dream. So as you know, when we're sleeping and we're dreaming, we're essentially paralyzed. There are only two muscles that are really working for us, our diaphragm so that we can keep breathing, and then of course our eye muscles. But in patients with Parkinson's, again, upwards of 50% of patients, you can lose this mechanism. And so when you're in your dream state sleep, your REM sleep, you can start to act out. A lot of people experience insomnia. This is difficulty sleeping. It can be a difficulty falling asleep or difficulty maintaining sleep. Restless leg syndrome is also very common. That's because it also involves dopamine transmission. Again, we know dopamine is heavily implicated in Parkinson's disease. And this is when people usually have onset of an abnormal sensation in their legs, which gives them an urge to move their legs and kind of move around. That gives them some transient relief, but it usually occurs more at nighttime. So there's a circadian rhythmicity to it. People can also have sleep apnea. This is a pause in breathing, or your oxygen may drop when you're breathing. And people can also have excessive daytime sleepiness. So this is going to be when you're excessively sleepy during the day, despite the fact that you're actually sleeping an adequate amount of time at night, and again, having an adequate quality or architecture of sleep. So sleep disorders and Parkinson's disease are caused by a number of things. You might have primary disease symptoms from the neuronal degeneration of sleep-regulating brain regions. Sometimes it can be medication-related. So for example, if you're wearing off in the evening, you're becoming a little more stiff and rigid and can't turn around, that may disrupt your sleep. Actually, I apologize, that's going to be PD-related. And then medication-related, there are some medications that we use, namely amantadine or selegiline, that can actually cause insomnia. So if that's the case, you might want to discuss the timing of the medication with your doctor, or even coming off the medication. So again, as I mentioned before, REM sleep behavior disorder is huge in Parkinson's disease. Again, it's characterized by a presence of muscle activity, which enables dream enactment. When people experience REM behavior disorder, it's an odd phenomenon because a lot of patients are very calm and pleasant during the day, but the dreams that they experience when they're acting out their dreams are usually very violent, very unpleasant. Usually there's maybe someone chasing them, or they're chasing someone or fighting them. And so most typical behaviors are going to include not only just kicking, but actually acting out your dreams. So you may be looking like you're punching an assailant or you're hitting them. You may be jumping, screaming, or laughing. One thing to remember as far as REM behavior disorder is concerned is that patients who are experiencing this generally do not get out of bed and walk, okay? They don't interact with their environment. They may grab a nearby object, but they're not actually interacting, and they're not necessarily going to be talking back to their bed partner. That's because there's also going to be some other things that may look like REM behavior disorder, namely, so if you think about it, REM behavior disorder affects people in the REM stage sleep. There are other abnormal behaviors that may occur in the non-REM stages of sleep that may overlap. Sometimes people who have untreated sleep apnea, they may have what we call dream enactment behaviors due to that. And then also periodic limb movements of sleep are when you kick at nighttime, and so it may be something like that. So unfortunately, as far as treatment for RBD or REM behavior disorder is concerned, there aren't that many treatment options available. What we try to preach the most is bedroom safety. So it's going to be important if you have a tendency to fall out of bed, have your bed low to the ground, maybe a soft cushion beside the bed. At some point, bed rails may be needed. You also want to make sure that you have any kind of sharp objects or sharp corners out of the way. So for example, you have a nightstand. All our nightstands are right next to our bed. They have a sharp corner. You fling out your arm, you fracture your wrist. So that's the main thing. Next, clonazepam is the most effective medicine for REM behavior disorder. That's a benzodiazepine. It's very effective, actually. It works in 90% of patients. The problem is that in our Parkinson's population and the older or elderly population, we really hesitate to use this medicine because it has a lot of side effects. It can make you groggy or unsteady. So as you can imagine, getting up in the morning, those are things that you would be concerned about. Melatonin is a naturally occurring hormone. It's the safest treatment for REM behavior disorder. It may or may not be effective, but again, it's going to be safe. You can take that in doses of about 3 to 15 milligrams at bedtime. So excessive daytime sleepiness. This is also very common in patients with Parkinson's disease. Upwards to a third to 74% of patients will experience this at some point or the other. Prevalence typically increases as the disease progresses, and it can also be associated with more advanced stages of Parkinson's disease, more disability, and more cognitive decline. There has been a growing recognition of so-called quote-unquote sleep attacks. Again, this can be a medication side effect. We keep talking about dopamine agonists are the biggest culprit in this. They can cause what we call sudden sleep attacks where patients suddenly fall sleepy, or they can just make you feel sleepier during the day. But otherwise, we've noticed that a lot of studies are starting to demonstrate that there might be a loss of the wake-promoting substance hypocretin. And so this loss is also starting to correspond to clinical stage of Parkinson's disease. So as far as treatment of excessive daytime sleepiness is concerned, the main thing is that you want to establish good hygiene. So these are all the common intuitive things that we do to improve our sleep. We want to make sure that we have consistent bed and wake times. Sometimes we have a tendency to fall asleep a little later on the weekends. We want to try to regulate and make that more consistent across the board. It's very important to get adequate exposure to light. Of course, that's obviously a little difficult in our Buffalo weather, but there are light lamps, and of course there's a lot of you go to Florida, so that's great. But make sure you get a lot of light at day, and then you also want to get darkness at night, so kind of regulate that. You want to avoid sedentary activities during the day. So let's be honest, if you're a little sleepy during the day, you're not doing much, you're just going to go ahead and doze off. The problem with that is it's going to end up disrupting your sleep architecture at night. So make sure you participate in activities outside of the home. Make sure that they're stimulating so that they prevent daytime dozing. Make sure you also can get physical exercise as much as you can. We know that it's great for Parkinson's, so it's also good for avoiding sleepiness. Of course, you want to do that appropriate to your level of functioning, but it's also going to help promote daytime awakeness, okay? The only caveat is to make sure that you avoid exercise about 3 to 4 hours prior to bedtime, because otherwise, of course, exercise is a stimulating activity. You don't want to make it so that you're doing it so close to bedtime that now you can't fall asleep. And then the other thing is just to make sure you talk to your doctor. Talk to them if you experience daytime sleepiness or sleep attacks. And if you're on a dopamine agonist, again, that may need to be decreased. So moving on to some of the neuropsychiatric manifestations of Parkinson's disease. Again, I like to include definitions. So when we talk about cognition, this is referring to different domains: memory, language, executive function, which is planning, and then, of course, visuospatial processing and attention. As far as cognitive impairment is concerned, about 25% of patients can experience mild cognitive impairment. That means you're having, issues in one of these domains, but it's not necessarily disabling. And then as you advance in the course of the disease, approximately 80% of patients with Parkinson's disease may develop Parkinson's disease-related dementia. And again, we talked about with some of the autonomic symptoms, if dementia is something that is prevalent or is an issue early on in the disease, you may want to start considering some of the atypical variants like dementia with Lewy bodies. So when patients with Parkinson's disease develop cognitive impairment, their types of symptoms can vary. Again, we talk a lot about executive dysfunction. People have trouble problem solving or taking steps in a particular action. They may have attention difficulties. They start to have difficulty maybe retrieving information. So you have those word finding difficulties, just can't find that right word. Sometimes remembering and learning information can be difficult, and then also visuospatial difficulties. So when we approach treatment as far as cognitive impairment is concerned, especially if something has occurred acutely or all of a sudden someone is not remembering something or acting a little funny, you want to make sure that there's no other medical cause that may be underlying that. So especially in the elderly population, look for underlying infections like a UTI and rule those things out. You can also test for vitamin deficiencies. B12 and vitamin D are commonly implicated. You also want to start making lifestyle changes. So it's important to get plenty of exercise. That's always going to be good for the brain. A good quality of sleep, and then also socialization. And one of the things I also forgot to mention in here is mood. So oftentimes people who have mood disorders will also potentially develop what we call pseudodementia or cognitive impairment due to that. Other things you want to address are, safety issues around the home, caregiver issues, and one thing that a lot of patients don't like to hear is when their doctor tells them that it may not be very safe for them to drive any longer. I myself have told many patients that, and they're not very happy with me, but it's always going to be a good idea to get a driver safety evaluation. They can do that at multiple facilities. Basically, you just want to make sure that you yourself are safe on the road and that other drivers are safe on the road. And then once we start to address all these factors, then you want to start to think about what medications might be appropriate. We have some cholinesterase inhibitors on the market. Very often, rivastigmine is used for Parkinson's disease dementia, and then NMDA antagonists like memantine. So psychosis. This is also another hot topic, especially in the past couple years. I'm sure a lot of you have seen that commercial on TV where patients are experiencing hallucinations, and I myself have had a lot of patients come in and say, "Hey doc, am I going to go crazy, with my Parkinson's disease?" I'm not going to say not necessarily, but it is very common, but you have to remember, it's usually something later in the disease process. But as far as psychosis is concerned, it refers to a spectrum of illusions, hallucinations, and delusions that can occur during the disease course. It can be present upwards of 40% of patients. When patients have hallucinations, they tend to be visual versus auditory hallucinations. So some of the psychiatric conditions, like, say, for example, schizophrenia, they often have auditory hallucinations. Having said that, about 10 to 40% of patients can have secondary auditory hallucinations, but these are typically very non-distinct. They're non-paranoid. They may be hearing voices in the crowd. Delusions, and we'll talk about some of the definitions in the next slide, again, are going to be very paranoid in nature versus in, say, for example, again, in schizophrenia, they're more grandiose. So these are going to involve very stereotyped themes. Is my wife cheating on me? Is she going to leave me? People are worried about patients, or people are worried about others stealing from them. So again, we always, say to our patients, are you seeing anything that's not there? But there's a range of things that can occur when patients with Parkinson's disease experience hallucinations or psychosis. So just to go through some of the definitions again, an illusion is when you actually misinterpret something that isn't there. So for example, if you're walking down the road and you see a lamp post and all of a sudden you think there's maybe a figure there, that would be an illusion. Patients sometimes experience passage hallucinations, and they have a sensation of a figure passing somewhere in their peripheral field. People can experience presence hallucinations, and that's actually the sensation of someone's presence when no one is actually there. So sometimes, a lot of times, patients may experience angels or maybe someone who has passed along, but that's something that I've heard quite often. You can also have formed hallucinations. So this is going to occur during wakefulness. They can be pleasant or frightening. So patients can sometimes see little children, small furry animals, etc. And then, of course, we get to delusions, and that's when you have a false fixed belief that's just not based in reality. And so as I mentioned before, most often, you will experience psychosis in the later stages of disease, but there have been some studies that have shown that patients may have some of the more minor symptoms a little earlier, and so this is something that correlates this with their UPDRS scores, which is something your doctor may use to kind of measure your stage of disease, but you're going to be having hallucinations without insight a little later. So some of the risk factors for psychosis, of course, dopaminergic drugs may cause hallucinations. Again, things like Requip, Mirapex, or Sinemet. The older you get, the more at risk you may be. Disease onset, if you've developed the disease a little later in the course of your life. Again, higher PD severity, those that may be a little more advanced in their motor stages of their disease. If they've had Parkinson's disease for some amount of time, those patients with cognitive impairment. Also, REM sleep behavior disorder seems to have a high association with this. And then, of course, if a patient has a lot of medical comorbidity and is on a lot of different other medications. So why are we, worried, or why are we concerned about patients with psychosis? Of course, they're likely to continue once a PD patient experiences it. And then at the end of the day, it's going to be associated with high caregiver stress. And then it's also, the burden is associated with increased rates of nursing home placement. Again, as far as management for psychosis is concerned, it's very similar to what we do with cognitive impairment. Again, if your loved one is all of a sudden experiencing severe or worsening hallucinations, you want to make sure that there's nothing else that's kind of muddying the picture. Are they having an infection? Is there some sort of metabolic disturbance going on? Say, for example, their electrolytes or even new medications. I had a patient who has been experiencing hallucinations for some time now. They're on medications, and all of a sudden they had an acute worsening. And it turns out that the nursing facility had started a couple new medications, and it was in that context that all of a sudden things kind of went wild. The next step you want to do is make sure you adjust your Parkinson's disease medications. We usually kind of go in a stepwise manner. You want to take out any kind of anticholinergic, so amantadine or artane, or actually artane, and then you might want to take out amantadine. Some of the MAO inhibitors, for example, Azilect or Selegiline, the DA agonists like Mirapex or Requip. Then you're going to start to think about whether you need your Comtan. And then usually levodopa is reserved to the end because we always want you to maintain your motor function. And then there are a number of medications that we can use. For a number of years, we were really reserved to using only a couple medications. Clozaril is actually very effective, but unfortunately, it can be very difficult to administer because it requires weekly blood draws and monitoring your blood counts. And so typically it's been reserved to psychiatrists. We've depended on Seroquel for a number of years. That's because it's one of the antipsychotic medications that has less risk of worsening your Parkinson's disease motor symptoms. And then now the new medication or the new kid on the block is Nuplazid, which has gained a lot of media attention. But that's what we have, which is probably the best tool that we have in our arsenal today. So again, as I mentioned at the get-go, this is by no means an exhaustive talk. I mean, if you wanted to really talk about all the non-motor symptoms we saw on one of those slides, it'd probably take a few hours. But just to, some take-home points for today, we want to remember that Parkinson's disease is not just a movement disorder. There are a number of non-motor symptoms that as you start to develop your disease, you'll start to have to deal with. It's important that we are aware of these and recognize these so that you can bring them up to your doctor. And if we can appropriately treat a lot of these symptoms, that can go a long way towards improving your quality of life. So again, make sure that if any of these symptoms come up, talk to your doctor about whether it may be Parkinson's related, whether it may be age related, medication related, again, but just make sure you have that open discourse. And that is it.